Good morning. It's always great to be back in Charleston. I appreciate the invitation to come here and speak with you all. I'm going to talk about out-of-office blood pressure measurement. I don't have to talk about the importance of hypertension. You've heard that from our previous three speakers. I have no financial disclosures. These are the objectives I want to walk us through over the next few minutes: review limitations of office BP as well as basic principles of home and ambulatory monitoring, discuss outcomes that have proven benefit using home and ambulatory BP monitoring, describe the guideline recommendations for hypertension diagnosis, and briefly touch on the pros and cons of each of these methods, and really that they are complementary methods to improve care for our patients. So this is sort of the audience interaction part of this talk here. So what I'm asking you to do is actually work at your tables, talk to one another. I'm going to set my phone here for 30 seconds to find the answer to this question. Which of the following are false? I'll let you talk amongst yourselves for 20 seconds, and I'll come back to you. All right, which is false? Task force recommends ABP monitoring as the reference standard for confirming diagnosis. True or false? That statement. True. Ambulatory blood pressure monitoring is the least cost-effective strategy for diagnosing hypertension. False. Office BP measurement is frequently performed incorrectly. Absolutely true. All right, I'll give you another 20 seconds for this one to read it over. All right, so we could do the same thing, really. True or false? Properly performed office BP, stronger predictor of outcome than mean BP on ABPM. False, right. That's properly performed office BP is a good thing to do, but it's not a stronger predictor. Mean BP on ABPM is stronger predictor of CVD outcome than properly performed office BP. True. Office BP, when properly performed, is equally predictive. Obviously, that's also false. All right, you don't have to spend much time to look at what's wrong with these pictures. Pretty much everything is wrong with those pictures. So when it comes to office blood pressure measurement, it does have many limitations. Poor quality control due to technique, using the wrong cuff size. When you need that thigh cuff, where in the heck is it? And you got to ask the medical assistant to find it, and hopefully she can. Improper patient position, feet are not on the floor, arm not at heart level, failure to allow 5 minutes of rest. And if you use that manual sphygmomanometer, assuming it's not broken because it's the aneroid one on the wall that's about 7 feet from the exam table and somebody bumped it, you could let the air out of the cuff too rapidly. You'll use digit bias, rounding to the nearest 5 or 10, and there are many other observer biases or problems, such as being able to hear, which carot cough sound to use, etc. Which carot cough sound to use on Monday, which one to use on Tuesday, those kind of things. So lots of limitations with office BP. Let's see, this thing seems to have frozen. There we go. Now, let's say you do it perfectly. Even when it's done correctly and you do it absolutely right in the office, it's still only a few readings. So that's a problem. And because there's substantial variability in that blood pressure does vary. So it's a moving target. And even when you do it right, it may not reflect a person's what we'll call true blood pressure or the mean blood pressure over the course of a day. Okay. So when you see a patient like this, 42-year-old woman with office blood pressures 150s over 80s, no signs of target organ damage, LDL's good, HDL's great, not diabetic, not on oral contraceptive pills, which might be raising her blood pressure, no family history of early CVD, you might be saying, well, I'm about to start medications because that's what the guidelines suggest we do, lifestyle plus medications in this blood pressure range. But there are clinical questions that should come to our minds when we see someone like this. First, are her office blood pressures accurate? If they're accurate, do they represent her usual blood pressure, or are these a series of one-offs or two-offs? So do you make the diagnosis of hypertension, which I like to emphasize to residents, the clinician makes the diagnosis, the machine does not. So do you make the diagnosis and do you start medications? Will the patient initiate and persist with medications, and how will you assess her blood pressure control? So one of the problems is that clinic blood pressure, office blood pressure, can overestimate usual blood pressure. In other words, white coat hypertension or white coat effect may be misclassified as sustained hypertension. Certainly it can underestimate as well, but that's a talk for another time. Overdiagnosis can lead to overtreatment, which is really causing harm to our patients, and so we want to minimize this. So that leads us to out-of-office options, which include two major ones: home blood pressure monitoring and ambulatory blood pressure monitoring. The questions then become, how do they compare? What are the pros and cons of each? Just as a side note, multiple studies I've seen have shown that pharmacy kiosk monitors are not recommended. They're notoriously inaccurate. And so while they may get us in the ballpark and they may prompt a patient to come in and talk to you, they're probably not what to use for reflecting a person's measurements. What is ABPM? Ambulatory blood pressure monitoring. It is a device worn by the patient. It is oscillometric in its sort of modality, pre-programmed and fully automatic. The machine automatically takes readings over the course of 24 hours, so you have an awake set of readings, a night set of readings, or a sleep set. It measures the blood pressure during a patient's normal day and night, and then the data are transferred to a computer for the report out. A report out might look something like this. This is quite a normal ABPM session. The green line represents sort of the older threshold. This one hasn't been set to new guideline threshold, but on this one it's set to 140 over 90. Should be set to 130 over 80, really. But you can see this person's blood pressure is systolic on the top, diastolic on the bottom, and its heart rate over 24 hours looks really well controlled. Sleep time periods indicated by the gray zone. And you see the morning surge when the person wakes up. From that kind of reading, you can get lots of data. You can get a mean overall blood pressure, you can get a mean awake, you can get a mean asleep, you can get the nocturnal dip, how much does that blood pressure fall during the night. It should fall between 10 to 20% ideally. You can see what the morning surge is, and you can even get what the blood pressure load is. In other words, the percent of readings above threshold. Is 60% of the readings above threshold, 80%, or maybe only 5 or 10%, that kind of idea. As you know, home, sometimes called self-blood pressure monitoring, is a device the patient purchases. You can go on Amazon and get one of these shipped to your house, probably by a drone or a droid or something the next day for about $30 to $50. They're oscillometric also. Patient puts the cuff on and pushes the button to take the readings. The patient obtains the readings when the patient desires to obtain them, which could be after an argument, when they have a headache, so in other words, all the wrong times. The patient documents ideally and shares ideally, or does not share those readings with the clinician. And there's the potential for remote connectivity for data, although the actual implementation of that is far from where we need to be. So an important paper came out in 2011 in the British Medical Journal with a systematic review of the 7 studies comparing clinic and 3 studies comparing home measurements to ABPM as the gold standard to see, well, how good are home and office measurements? And in meta-analysis, came up with these numbers. Office blood pressure has a sensitivity of about 75% and a specificity of about 75% for accurately diagnosing or correctly diagnosing hypertension based on 24-hour ABPM. And home blood pressure came up with a sensitivity of 86% and specificity of 62%. Now we can look at the confidence intervals and debate the level of accuracy of these numbers, but the bottom line was, and their conclusion was, that neither clinic nor home were adequate as a single diagnostic test to confirm the presence of hypertension or what the person's blood pressure usually was doing. The Lancet, shortly thereafter, and by some of the same authors, published a cost-effectiveness study that was basically a Markov model, taking a hypothetical primary care population of 1 million patients over 40 years of age with a screening blood pressure in the office of over 140 over 90. And they modeled them out over a horizon of a lifetime to see what the cost of treating, not treating, et cetera, would be over the years, because they're interested in the UK, how much is this going to cost us and what's the right thing to do based on sort of cost effectiveness. And they noted that ABPM was the most cost-effective strategy for the diagnosis of hypertension, and that was based on not giving people pills to treat white coat hypertension over the course of many years. They noted it was cost-saving for all groups and resulted in more qualities for men and women older than 50 years. Of course, what they didn't model in this was the sort of the opposite effect. What happens if you use ABPM to capture people who have so-called masked hypertension and treat them? That's, again, a story for another time. But based on that systematic review in the BMJ and the cost-effectiveness study in the Lancet, the UK guidelines way back in 2011 recommended ABPM to confirm the diagnosis of hypertension in patients who screen positive in the office prior to starting medications. You fast forward now 4 years to the United States Preventive Services Task Force, who commissioned a systematic review. A couple of other studies were found and published in the ensuing 4 or 5 years. They identified 9 studies that compared or evaluated the 24-hour predictiveness of ABPM, because they actually wanted to first, again, show which is the most predictive for cardiovascular outcomes. To include in this systematic review, the study had to include a cohort of patients who were followed forward in time and that had to have baseline blood pressure measurement of ABPM and office or home monitoring so that they can make comparison on outcomes of overall mortality and CVD events. And again, what was shown here is they found 4 studies that demonstrated that for each 10 millimeter increase in blood pressure, in ambulatory blood pressure, when adjusted for office blood pressure, so it didn't matter what your office BP was in the end, it mattered what was on the ABPM, That was significantly associated with fatal and non-fatal stroke. And 6 additional studies, each 10 millimeter increase in blood pressure associated with 11 to 42% increase in CVD events when adjusted for office blood pressure. So their conclusion, just like the BMJ conclusion, was ABPM consistently and statistically significantly predicted stroke and other CVD outcomes independently of office blood pressure. So when you have ABPM, you really have the best data available for that patient. The second step in the systematic review for the task force was to say, okay, ABPM seems to be the best predictor. Now can we say how good, again, is office blood pressure for diagnosing hypertension when compared with ABPM? So this is a table I put together based on the Annals paper that shows that when you take office blood pressure and you look at how much hypertension is confirmed by 24 hours, you can see that it got it right 35 to 89% of the time, depending on the study. Again, a little bit of heterogeneity in these studies. But would you accept a test getting it right somewhere between 35 to 89% of the time? Probably most of us would not accept that. Task force then came up with their final recommendation that says we ought to strongly recommend outside of the office clinical setting measurements to confirm the diagnosis of hypertension prior to starting treatment. Notice that this was the final recommendation because if you looked at the draft recommendation 6 months before, it actually stated ambulatory blood pressure monitoring there, but they softened this recommendation. Why? Because it's not easy to get ABPM, and home blood pressure monitoring then becomes sort of the alternative. They do say in the text, if you read the statement carefully, ABPM is the best method for diagnosing. The task force goes on to say it's the reference standard. Home blood pressure monitoring is an acceptable alternative. So if you go back to the lady in the first sort of case there that we had, this might be her ABPM. She comes into the office, gets the 24-hour monitor put on, and the first few readings are actually conducted in the office. 180s over 110s. You see the red spikes. But as she settles in, sort of after that first 2 hours, which we might deem the white coat period, she really settles in and leaves the office and then, gets to her house or wherever she's going, and her blood pressure settles in nicely, and then she has a normal nocturnal dip. She has a normal morning surge that's not over the top, and then she goes about her day, and she does have a spike around lunchtime, maybe driving down the highway in traffic or something, but you see what you get there, and you can look at the total, what you get on the report. That's 40 readings of blood pressure over the course of 24 hours. You can take the mean overall blood pressure. For her, it was 130 over 79. Even with those spikes in the white coat period, if you take those spikes out, her mean drops a considerable amount as well. Her mean awake was 134 of 83, mean asleep 109 over 61. She has a nocturnal dip of 20% systolic, 29% diastolic, and 17% of her readings were above threshold. So this might be a person you would say just do lifestyle on and come back and reevaluate in a few months. Which of the following statements is correct? About 1/3 of patients with suspected resistant hypertension have normal mean BP on ABPM. Patients with resistant hypertension should not have ABPM. ABPM cannot be used to detect white coat effect in patients on BP lowering therapy or none of the above. A is correct. About 1/3 of patients with suspected resistant will have normal BP on ABPM. The second was pretty funny to me. I made that up. I don't know why a patient with resistant hypertension would not be eligible for ABPM, but it's hard to get it paid for. In clinical practice, assessment of white coat effect is the only condition reimbursable by Medicare since 2001, although when some colleagues and I looked at Medicare data and published the results of this, there were a lot of reimbursements for ABPM that, as long as you had the code elevated blood pressure, were paid about $56 on average for the session. But other clinical indications besides looking for white coat are to confirm hypertension in children, to again evaluate resistant hypertension. When you have the patient on the four drugs or the third drug and you're about to start your spironolactone, maybe you should check to make sure that they indeed have uncontrolled blood pressure on ABPM, because patients with resistant hypertension still exhibit white coat effect. Their blood pressure rises in the office. Maybe they think it's a self-fulfilling prophecy. Every time I go to the doctor's office, my blood pressure rises, and so they're worried about that. Labile hypertension, orthostatic hypertension, many reasons to do an ABPM besides just looking for the white coat effect before you start medications, and CMS is currently reviewing this to determine whether we ought to start reimbursing for ABPM for more than the initial indication. So what about a patient with resistant? 48-year-old male, recent blood pressures are 158/84, 165/90, on 3 drugs, including a chlorthalidone. They're all once daily. Pharmacy records show he's taking them, and he reports taking them. So what do? Well, it turns out, and there's lots of data out there besides this one study, but it turns out that many resistant hypertension patients are actually well controlled. So the graph shows the percent of people with controlled blood pressure on ABPM by drug. So on no drugs, you can see that 32% sort of controlled with both awake and 24-hour, and the white bar showing sort of the ABPM 135/85 threshold. So about a third of patients with who are suspected to have resistant, they're on multiple drugs. When you put ABPM on them, they actually have controlled blood pressure. So it's not an unreasonable step. There are practical issues, however, which I've alluded to, not yet widely available. Few providers and their clinical staff are trained in this, and trained clinical staff is the key because you want to get good data from your ABPM. It's recommended to do during a workday, which can be a nuisance. If one of you are wearing an ABPM right now during this talk, depending on the periodicity of the programming, every 20 minutes we'd hear brrrr. As it inflates, and if Jan were wearing it, he'd be all embarrassed like this. He'd have to hunker down because it's annoying and distracting. It does limit some physical activity, so you can't, go for a big jog. You can go about your normal day, though. Go to the grocery store, drive home. And that actually speaks to one of the potential advantages or differences of ABPM compared to office, and that is it's capturing our blood pressure during what we do, not capturing it with your feet on the floor necessarily after 5 minutes of rest. Is that what our target organs are seeing, and is that why it's a better predictor? So my friend Shimbo calls this ecologic, sort of ecologic blood pressure. What's your blood pressure doing during your normal day? And while tolerable, it is inconvenient. So wearing it for 24 hours is a bit of a pain. And it's possible to get insufficient readings, which is why I said it's so important to train clinical staff on this. Because if they go about wearing it all day, what I didn't say yet is that they can't see the blood pressure reading on the monitor. So they don't know if it's getting a reading, except that if it errors, it will try again. If it errors again, it will try again. And then it'll give up and wait the 20 more minutes. It's possible that it's going off 24 hours, the patient's leaving it on there, not knowing, and they get to the clinic to download the data, and it's just lines and no readings. That you don't want to happen because they went through the trouble, and if you want the test, that means doing a repeat blood pressure 24 hours, and no one really wants that. So we did a study on tolerability where we had patients wear it twice over a week period, and of course we paid them, so that's another difference. But the most bother when you ask them, like, how did this 24-hour ambulatory blood pressure monitor, how did you really cope with it? The most bother is with sleep. People do say that it wakes them up, not necessarily keeps them up all night, but 8.6% in our studies said they removed it at some point during the night. So this is one reason that many of the guidelines say they use awake blood pressure. So they use the awake period to sort of categorize things. In other words, if they did take it off, you still get valuable information if you were able to capture 13, 14 hours of awake readings. It's still very valuable. There's also some adverse effects, discomfort from wearing the monitor, skin irritation, bruising. If a patient is on a blood thinner and their blood pressure monitor is going off every 15 to 20 minutes for 24 hours, you can imagine that when you take it off, you might see a pretty impressive bruise there. And this sort of tolerability issue does limit its use in monitoring blood pressure control. So in other words, this is a diagnostic confirmatory test, but then is it going to be something you do every 3-6 months to assess how the blood pressure is going? Probably not. So that's an issue, which brings us to sort of a home blood pressure monitoring use. Which of the following statements is not correct about home blood pressure monitoring? Patients should be taught proper technique for home blood pressure monitoring. Home blood pressure is a better predictor of CVD outcome than properly performed office. Home blood pressure is more feasible than obtaining ambulatory BP monitoring. Very few home blood pressure monitors have undergone validation studies. So A is correct, B is correct, C, it's probably kind of correctish, it's more feasible because it's harder to get ABPM. D is not correct. There are many home blood pressure monitors that have undergone validation studies. So it's another method that you can use to obtain blood pressure measurements outside the clinical setting. It's also a better predictor of outcome than office BP. The task force review showed that. The evidence base is growing, but it's not as strong as with 24-hour ambulatory blood pressure monitoring. And you might think of it as good for ruling in, but not as good for ruling out hypertension. It's why the guidelines talk about if if you screen positive in the office, you do home and it's negative, which do you believe? You could use 24 hours as a tiebreaker. If you screen positive in the office and you confirm positive at home, you can probably believe that. They have high blood pressure. So that's why it's better for ruling in and ruling out. Well, I'm up almost at time here. I'm winding it down. Maybe more feasible method, widely available. It's relatively affordable, or if an office had them, they could be loaned to the patient and brought back. And when systematically performed, in other words, you give them a system, 3 readings in the morning, 3 readings in the evening, 5 days in a row, bring me the data and let's look at it together. That correlates reasonably well with ABPM daytime average, sort of correlation on the order of 0.6, 0.7, depending on the study you read. Home blood pressure monitoring also has value beyond the diagnosis. Monitoring blood pressure control, it is easier to use for that. Multiple people in the family could use it. You can evaluate possible medication side effects. If the patient says, I'm feeling dizzy on my blood pressure medicine, maybe you can have them take some readings and see. And then maybe it encourages adherence as well. So diagnosis can be useful for home blood pressure monitoring. Home blood pressure monitoring is also good for control. May increase self-efficacy. They see the effect of taking that ARB and their diuretic. May improve adherence. And there's a paper in DMJ and multiple papers besides this meta-analysis that shows people who monitor their blood pressure outside the clinic with home BP seem to have a better blood pressure control, 4.25 millimeters of mercury on average in meta-analysis. There are still some problems with it. It does rely on proper technique. The patient needs to be engaged, and it does require effort. We clinicians sometimes have concerns over the trustworthiness of the data. I always think about if they bring me the readings on a napkin that looked like it was in their glove compartment, and I usually don't trust those. If they bring me the diary or the graph from the engineer that used the Excel spreadsheet, those are probably pretty good. But it still does miss large segments of the day, and it does miss nighttime readings, although there are monitors in the works that can do that. Many people use their home blood pressure without telling their doctor or their clinician. Many have never had their monitor checked. And then frequency of using it is largely patient-driven. People talking about, I only check my blood pressure when I feel like it was high. That's not the right way to do it. So they need guidance. They need to be taught. They should make sure their cuff size is correct. They should, if they have memory in their blood pressure monitor, bring it with them. You can check it in your office, compare it to your readings, see where you are. Are you within 5 millimeters in your office? So you have a sense of what those readings mean and how they compare. There's a good website, dabbleeducational.org, and there are other sites that you can check and that sort of show you which monitors have been independently validated. So you can go on a site like that, and you can look at a list and say, this monitor's been recommended, or it's sort of corresponding model. So the case may change, but as long as the innards are the same, that model can be recommended. So that helps you decide or guide your patient. So in terms of home versus ambulatory, I'd say they're best thought of as complementary methods, not necessarily one better than the other. They provide somewhat different information. It depends on what information you need as to whether you say, I need an ABPM or I want you to do home blood pressure monitoring. Ambulatory is more expensive and inconvenient. It's not widely available, while home is affordable and easy to use. Ambulatory is good for clarifying BP status, in other words, a new diagnosis or control. Home monitoring is great for assisting in clarifying blood pressure status. It's better than office for predicting risk. Ambulatory is, I put best question mark for predictor of risk because there's not been head-to-head studies of which one predicts risk the best. There was a systematic review looking at both and found that there aren't anything that really gives us a clean answer on that one. The use is limited because you can't do a lot of ABPMs, but home monitoring can be used long-term. It can assist in ruling out white coat effect. ABPM is the gold standard to rule out white coat effect, against which other things are compared. ABPM provides nocturnal measurements and BP variability, which can be valuable complements to your management of hypertension. And maybe in the future, probably in the future, home monitors will be able to do the same thing.